Life's beauty lies in its intricacies. This journey gives us problems to solve and lessons to learn. While in the entire process, good health remains a principal asset many do not value until sickness comes. So if you think wellness is expensive, you may try illness, but remember, health is an investment, not an expense. Welcome, ladies and gentlemen, to Dr. Tapaswini's Corner. That's me, and I work as a head and neck cancer surgeon. The discussion today will highlight gastrointestinal cancers with main focus on gallbladder and stomach. Throwing light on this issue, we have Dr. Shailesh Shrikhande. You are the Deputy Director of Tata Memorial Hospital, Head of the Division of Cancer Surgery, and also the Chief of Gastrointestinal Hepatopancreatobiliary Surgical Services. Having trained yourself in pancreatic surgeries from the University of Bern, University of Heidelberg, you are among the few surgeons worldwide to have successfully performed more than 1,000 Whipple's operations. Your academic achievements are enormous. In a recent study conducted by the Stanford University, USA, you've been ranked among the top 2% researchers out of a total of 150,000 researchers worldwide. You are the only second Indian surgeon in the last 140 years to be conferred the honorary fellowship by the American Surgical Association since its inception in 1880. In recognition of your work on GI and pancreatic cancers, you've been conferred the honorary fellowship by the Royal College of Surgeons of England. Welcome, Dr. Shailesh. We are so grateful that you could manage some time off from your hectic schedule for the show today.
Thank you so much, Dr. Tapaswini. A real pleasure and privilege to be on this program and looking forward to this program for a good cause.
Indeed, it's an honor to have you here today for the program. So if we look at the statistics of overall cancers, where in the ranking are the GI cancers and how serious is this problem in India?
So I think, fortunately for India, even now, gastrointestinal cancers are not as common as you would see in the West, in Americas, in Europe, as well as the Far East.
Okay.
So we clearly have certain protective mechanisms which is helping us. This is one part of my statement. The other part of the statement is that gastrointestinal cancers are on the rise as India continues to get more and more urbanized, as awareness continues to increase, and our ability to detect cancers also continues to increase due to better diagnostics as well. So we clearly see an increasing and an alarming trend in gastrointestinal cancers, which will be a major problem for the next 1 decade.
What are the various causative factors of this group of cancers? And is it correct to label it predominantly as a lifestyle disease?
Yes, I think you already answered in your question, because it is the lifestyle disease predominantly. A lot of things which are the result of environment and due to a result of modernization or so-called urbanization, we tend to adopt a number of lifestyles or habits which are not really ideal. So some of the conventional causes which are responsible for many cancers are also applicable for gastrointestinal cancers. Principal among this is going to be tobacco and alcohol. In addition to this, you're going to be having things with diet. A diet which is going to be very rich in fats, a diet which is going to be less in fruits or vegetables, obesity, diabetes, and lack of exercise, coupled with environmental pollution, are all factors which could play a role in the development of gastrointestinal cancers.
So if we look at the eating patterns all over the world and also in India, so what sort of eating pattern is implicated in these GI cancers?
So the good part is that if you have a diet which is rich in vegetables and which is rich in fruits, the chances are that you might reduce the incidence of developing cancers of the gastrointestinal tract. Preserved foods, salted foods, or salt which is used as a preservative, meats, a diet rich in fats clearly contributes to an increased incidence of carcinogenesis in the gastrointestinal tract. The causes for this could be very many, and this could very well be a situation where you have transit time of the gastrointestinal tract being far more. As a result of that, you will allow carcinogens to develop. So a diet which is constipating, a lack of exercise is all going to come together in a multifactorial cause for development of gastrointestinal cancer.
Okay. So if you look at stress, it's almost become part of everyone's life. There's so much of altered bowel habits, and that's quite common. When does it ring an alarm bell?
So, well, I think this is a difficult question, but there is clearly a connection between the mind and the body.
Right.
So a mind which is ill at ease may not necessarily give rise to a disease, but will give rise to a disturbance. There is a difference between disease and disturbance. I get a whole lot of patients who are actually having a disturbance and large number of files and huge case summaries, and they have nothing really wrong with them. And that's clearly a situation where the mind is overworking, and that's having a physical impact on the body. There is no question about it. But having said that, should it ring an alarm bell? Any deviation from your normal lifestyle, if that deviation is going to last for more than 10 or 14 days, I think it's time you need to just not ignore it completely, but to visit your doctor and follow certain precautions so that you might be able to detect a problem if there is one.
Okay. All right. So if we look at the GI cancers as a whole, which among these sites they present early and which are those which present late?
Tumors which are going to be in locations where the obstructive symptoms are going to come in late, they would tend to get detected late.
Okay.
When do you have cars honking on a road? When there is a complete traffic jam. If there is traffic but cars are moving well, people usually do not honk. The same thing happens, that a tumor begins in a very small way and it starts to gradually obstruct. And only when the symptoms are such that the obstructive symptoms have become large enough that you tend to detect it. Having said that, that's the full tumor. But tumors can give rise to a whole other sort of symptoms. You can get a feeling of being feverish, malaise, lack of appetite. You might lose blood. So these are simple tests which can be done for you to be able to suspect or detect that something is wrong with the gastrointestinal tract. So I think you have obstructive symptoms, you have symptoms due to tumors. So large bowel and small bowel have different symptomatology. Gastric has different symptomatology, and hepatopancreatobiliary, especially biliary and pancreatic on the right side, would give rise to something like obstructive jaundice, which will be painless, but you will get jaundice which is different from the jaundice of hepatitis. So these are some of the cancers which might be detected early. On the other hand, you have an exophytic growth or a tumor going outside of the stomach or a tumor in the tail of the pancreas. They can assume very large proportions before they are detected because they make a noise not by obstructing, they just make a noise by the sheer size that they can assume. And then they start causing symptoms. So some of these cancers are detected late, unlike the luminal GI cancers.
But when we look at the various symptom profiles that you just told us, does it also help us to differentiate whether this is a benign pathology? Because benign can also have lumps. They can also cause obstruction. So what are those symptoms which actually alarm the individual that this is something which is not to be ignored?
So those are the conventional symptoms. But you know what? By the time you have those symptoms, you are actually dealing with an advanced disease. So if you start saying that it's going to be very low hemoglobin, completely altered bowel habits, where you have to go to the toilet 8 times in a day when you are normally going once in a day, or when you have abdominal distension, or you have feeling of vomiting and nausea, these are situations where tumors are already quite advanced. So to address your question more precisely, any deviation from your normal routine or habit, irrespective of whether a tumor is benign or malignant, should prompt an investigation out of concern. An
Okay.
investigation done earlier is going to help us in our fight against cancer.
Right, right, right. So, as a surgeon, how commonly do you find that you go ahead thinking that it's a benign pathology and suddenly you realize on the table that this is a malignancy that you are looking at?
So I can tell you that this is uncommon, perhaps because
Mm-hmm.
I have a referral bias because I work in one of the largest cancer hospitals in the world. But having said that, I treat a whole lot of patients with benign problems. So I think we clearly have a situation where in the vast majority of the cases, what we can do nowadays with preoperative evaluation and clinical judgment,
Right.
and in some instances, even an endoscopic biopsy, we would not be caught out on the
Mm-hmm.
operation table. There are situations where the best of radiology and the best
Yeah.
of diagnostics continue to keep us in a dilemma, and we would
Mm-hmm.
not know whether we are dealing with a malignant or a non-malignant pathology. In such instances, that's
Right.
where I call decision making is extremely important. That if that needs to come out, if there is an element of doubt, our patients are counseled well and they are nevertheless offered a resection, even if the
Mm-hmm.
pathology is benign. This would happen in about 3 to 4% of my cases, not as an intraoperative surprise, but
Okay.
where we preoperatively only have a doubt that this might well turn out to be benign, but that number is about 3 to 4%.
Now let's focus on the gallbladder cancer. So if you look at worldwide, there's a predominant geographic variability in its incidence. We have high rates in South America, and in India, the Gangetic belt seems to have high numbers. Is this fact correct? And if it is, then why is it so?
Gallbladder cancer is considered to be an endemic disease. So if
Okay.
you look at the incidence per 100,000 population of gallbladder cancer, we are somewhere similar to what Japan is, 4.5 to about 5 per 100,000. But if you just move to North and Northeastern India, and
Right.
this number clearly jumps to up to 20 per 100,000. So there's
Mm-hmm.
something going wrong, and there is clearly an impact of the environment, which is playing a role in the development of this aggressive gallbladder cancer. So we have always looked and we've done a study where certain heavy metals and pesticides and effluents from industries is going into
Okay.
the Gangetic plains. And we wonder whether there is an impact of these factors which are responsible for development of gallbladder cancer. But that's
Mm-hmm.
one. The
Okay.
second thing that we clearly need to know, and we still haven't found an answer for that, is going to be biliary parasites. We
Mm-hmm.
know that in China and in
Mm-hmm.
Hong Kong and in Transkai region of China as well, you have the liver fluke or the Clonorchis sinensis, which is responsible for hepaticolithiasis, liver cancers, and biliary tract cancers. When I say biliary tract, it doesn't necessarily mean only gallbladder cancers. It can mean cholangiocarcinomas also, which is
Okay.
essentially the biliary epithelium. So in India, I would strongly suspect that we have certain parasitic infections. We are yet to elucidate and show a clear cause and effect relationship,
All right.
but these are also playing a role in development of gallbladder cancer.
Okay. Often we hear that the patient was being operated for gallstones, and suddenly the surgeon realizes that there is a gallbladder cancer. So, what is the correlation between the two?
Gallstones and gallbladder cancer. Is it a cofactor? Is it just an innocent bystander?
Okay.
I want you to understand that this is not very well defined anywhere in the world, even today.
Uh-huh.
America, one of the commonest operations in the United States is a cholecystectomy, more specifically laparoscopic cholecystectomy because of gallstone disease. But the
Right.
incidence of gallbladder cancer in America, less than
Mm-hmm.
1 per 100,000. So
Okay.
it's not a straightforward association between gallstones and gallbladder cancer, but perhaps size of the stones,
Okay.
duration of the disease,
Mm-hmm.
and recurrent attacks of gallstone disease are perhaps responsible for development of inflammation and causing cancer, because gallstone disease is far more common and perhaps differently seen in North and Northeastern India again, as compared to, say, the city of Mumbai or Gujarat or Goa or Karnataka, where also you get a lot of gallstone disease, but you don't get gallbladder cancer. So I
Okay.
think Gallstones are important, but they are a cofactor. They are not the sole factor driving the development of gallbladder cancer.
We hear some bacterial infections in the causation.
Yeah, salmonella, this again, a very well-defined cause and effect relationship has not been defined, but we would certainly be exploring the work of bacteria, parasites, inflammation, gallstones, and heavy metal poisoning, etc. All these, there might be a complex interplay of all these factors that result in development of gallbladder cancer.
As we talk about gallbladders being more common in females, the 3 Fs that is commonly associated with, any association with age?
We know that gallstones are seen more commonly in women. We know that a large number of gallbladder surgeries are done in women and men. But the data which is out there, which is based on registries, hospital registry, as well as population-based registries, they don't show a big difference between the men and the women. That's one, data-wise. And the other aspect is that is this a problem exclusively with females or something to do with age? I think long-standing inflammation has clearly got an impact on development of cancer wherever in the body. And if you look at the Indian philosophy, there is one strong thing which the Indian population has, and that's tolerance. So unless and until there are severe symptoms and pain, pain is the only point of contact between a patient and a doctor. Unless there is pain which is not being treated by all means, only at that point in time a patient chooses to go to the doctor. So I think they do come to us much later than normally what they would do in some of the more advanced, more educated nations of the world. So I think long-standing inflammation might be having an impact.
Okay. But then how true is it that most of the gallbladder cancers present late?
This is true. I would still get about 60 to 70% who are advanced and cannot be offered surgery. But we would be able to offer definitive curative surgery in about 30% of these patients.
And what about the survival figures?
So it depends on whether you are able to treat it with radical surgery or not. There is clearly a stage-dependent survival. So if you're looking at stage 1 and stage 2, you will get more than 90% of patients who are going to live with radical surgery for gallbladder cancer. So the key, as with all solid tumors in the entire GI tract, if you have localized disease and you can do radical cancer surgery with complete oncology clearance and principles being followed, and you are in stage 1 or stage 2, you will get survival which is anywhere between 70% to 90%. But this number of stage 1 and stage 2 is a small. So you will have the numbers which are predominantly stage 3, which are also offered surgery. But stage 3 surgery patients also you will get about 40 to 60% who will live for 5 years. The problem comes when you put all these patients together and you say, what's the survival of gallbladder cancer? Stage 3, stage 1, stage 2, everybody together. And then you are reduced to 25%, 5 years survival for specialized centers offering surgery for gallbladder cancer.
A lot of information to be carried home on gallbladder cancers. So let's talk about stomach, another important GI cancer. So if you see the cancer-related deaths worldwide, cancer stomach has been the leading cause through most of the 21st century. A high incidence in Japan, Korea, Venezuela, and where in India do we see them most and why?
So I would slightly disagree with you in the sense that gastric cancer has been predominantly a big disease in the past century.
Right.
In
correct.
Century also, it remains one of the top killers. There is no question, but it's actually showing a degree of decline. More the education, more the awareness, better the socioeconomic strata, you are actually getting to see less and less of gastric cancer than ever before. So do I see a lot of patients of gastric cancer? I do. But if I look at the denominator of the country, the incidence is gradually becoming a little bit less. So that's one improved news, like cervical cancer in India, that the numbers are slightly going down with better socioeconomic status and better awareness.
Okay.
To address your question the other way, when you look at Japan and Korea, these are two countries where they have screening protocols in place.
Correct.
And that's because it has been endemic in those countries. Like gallbladder cancer has been endemic in northeastern India. Gastric cancer is a disease of Japan, Korea, the Far East, and incidentally, the northeastern part of India, along with some parts of Kashmir and some parts of Tamil Nadu. Now, why is the incidence so high in Japan and Korea? If you look for it, you will find it. And they have done screening protocols because that's been a major problem. But the vast majority of gastric cancers treated in Japan and Korea are stage 1 or early gastric cancers, and less of them are stage 2. They hardly treat stage 3 and stage 4 gastric cancers because they've got a screening program for smaller countries with 100% literacy, with advanced endoscopy available at least in all their major cities. This doesn't happen in India. So I do see a lot of stage 2, stage 3, and stage 4 gastric cancer in India. So yes, is it amongst the top 10 cancers in India? It is.
It is. So we talked about some states. You talked about Kashmir, we talked about Assam, Tamil Nadu. So is this something to do with their eating patterns, or are there other causative factors?
We clearly know that meats which are preserved and fish which is preserved, not just sea fish, but even the river fish, which is being consumed in some parts of the country. So anything which is too spicy, a diet which is rich in chilies, a diet which is excess in rice, a diet which is focused on salt, which is used as a preservative, are some of the factors which are responsible for causation of gastric cancer. On the other hand, fruits and vegetables perhaps confer a protective effect when it comes to preventing gastric cancer in India.
So how do these patients present in the clinic?
So unfortunately, since our medical college days, gastric cancer is considered to be sadly the king of death, because by the time you detect it, because the stomach is very capacious, unlike the small intestine, if a tumor is growing inside the stomach, as I mentioned to you, unless there is a complete traffic jam, it doesn't make a noise. By the time you have a palpable tumor in the stomach, or you lose a lot of blood, or you reach a state of vomiting, this is already very advanced gastric cancer, minimum stage 3, if not stage 4. But I think simple basic principles would be that after the age of 35 or 40, men should not be having low hemoglobin at any point in time. Sometimes with women, you can think that it's because of their menses or due to malnutrition. With men, if there is any hemoglobin which is lower than normal, it should alert you for doing an examination. And that's how we would be able to detect gastric cancer early, by wider use of basic investigations, and if required, adding an endoscopy. But if you are going to look for weight loss, loss of appetite, palpable mass, and anemia, this is already a very bad situation and unlikely to be stage 1 or stage 2 gastric cancer.
Okay. But can it run in families?
The vast majority of gastric cancers and vast majority of gastrointestinal tract cancers, barring colorectal cancers, are actually sporadic cancers, and they are not really a hereditary problem. That percent would be 1 to 2%. But vast majority of the cancers, and this is what I want our audience to know, are sporadic, man-made, and created because we have not lived a life of moderation. If you balance it out, cancer is an uncommon event even now.
We were talking about screening, which is so much, which is so religiously done in countries abroad, but it's probably not a feasible option in India. Besides endoscopy, is there some analysis that we can do on the blood and detect that, yes, this individual can have or is having?
To be honest, we haven't discovered an ideal biomarker to do an easy test. Even screening abroad is not something which is routinely implemented and successful. Colorectal screening and breast cancer screening has succeeded in the United States, and Korea and Japan, to an extent, have succeeded for screening with gastric cancer. My suggestion and thinking is to try and see in selected pockets where we know we have a high incidence of gastric cancer, we should look at the ideal goal of developing screening programs for a vast country like ours.
Absolutely.
Detect them early, treat them, and reduce mortality due to the cancer.
Absolutely. So you did mention about breast cancer. So when we look at breast cancers, there is a role of prophylactic mastectomy in patients who have a BRCA mutation. Is there something there in gastric cancers also where you do a...
As of now, there is no biomarker or there is no mutation which can justify a prophylactic surgery.
Okay.
The closest in the GI tract that we have come for prophylactic surgeries would be not in India, and I'm not advocating this. I should be very clear about it. I don't want to send out a wrong message here.
Right.
But in Chile, they came to know that it is principally the gallstones which is responsible. So they have encouraged laparoscopic cholecystectomy early in Chile, even for asymptomatic gallstones. And they have shown that there is a decline in incidence of gallbladder cancer in Chile. I don't want to use this platform to say do prophylactic gallbladder surgery, but certainly nothing for stomach, nothing for pancreas. Some polyposis syndromes and situations in colon cancer, yes, we would do something known as preventive surgery for colon cancer, for colon, to try and prevent colonic cancers.
So as we said, prevention still remains the key to everything. So what are the preventive measures that you would advocate?
As I mentioned to you, I gave you this answer partly as to what is driving these cancers. And you started off by telling me about lifestyle.
Yeah.
How about ensuring that we avoid a diet which is rich in fats? How about reducing our carbohydrate intake? How about we giving ourselves 40 minutes to 1 hour of exercise every day, looking after our own self? How about working on our mind to stay only positive? How about being disciplined as regards checking your blood sugar and your hypertension and avoiding the development of diabetes and hypertension, which is clearly invented by man largely? If you take care of some of these things and lead a life of moderation, cancer, I repeat again, is an extremely uncommon event and you will prevent it. Avoid smoking altogether. If at all you drink, it should be a truly social drink, and then you will not get cancer.
That's a lovely message, and I hope it should get into the heads and minds of our listeners. But as we come to the end of this program, and since you are such a great researcher and you've been extensively working on this particular field, what are the challenges do you think we face in our country, and how do you propose that we should be working on them?
There are multiple areas where we need to work on. We need more doctors.
Okay.
We need more nurses. We need more infrastructure. Tata Memorial has embarked on creating a much better infrastructure than ever before.
Right.
We are a center of excellence, but that doesn't mean we want the whole world to come to Mumbai for treatment. We will continue offering world-class treatment. So one is infrastructure development. The second is, if you look at the proportion of patients and doctors, it is something like one doctor per 390 in America, while in India, that ratio is 1 per 2,000, if not more than 2,000. So how do we encourage our younger people to stay inspired in this materialistic world and try to see what is special about our profession? I think this is one profession where you give and give with enormous satisfaction and gratification without expecting anything in return. So second part of your question is that we require skilled manpower, not just of doctors, but physician assistants, skilling people, so that the people in different strata of society can participate in delivery of healthcare. And then we want to kind of develop a kind of a center which is available in every major state in the country, so that, you know, a doctor close to home is the best doctor. We have improved a lot in the last 2 decades, but clearly there is a whole lot of work that still needs to be done. But I think that work has to be done by people like you and me, and we have to motivate more to do it.
Absolutely. So health for all, you know, it has to be accessible to every individual. Thank you so much.
Preventive oncology. Preventive oncology.
Yes, I fairly agree with you. Thank you so much, Dr. Shailesh. And it was wonderful talking to you. And the talk has been really educative and informative. And thank you to all the listeners. See you next week with another episode. Till then, goodbye.